Welcome, everyone, and thank you for standing by. At this time, all participants will be on listen only until the question and answer session of today's conference, at which time you may press star 1 to ask a question. Today's conference is being recorded. If you have any objections, please disconnect at this time. I'd now like to turn the meeting over to your host, Ms. Margaret Farrell. Ma'am, you may begin.
Great. Thanks so much, Amber, and good afternoon, everyone. I'm Margaret Farrell, and on behalf of the National Cancer Institute, I'd like to welcome everyone to the February Research to Reality Cyber Seminar. It's been 5 years now since NCI launched Research to Reality's community of practice, and we truly envisioned at that time that this community would be one that could bring together researchers and practitioners and engage in ongoing discussions around both the promise and the perils of evidence-based cancer control programs. Last week, we marked World Cancer Day, and when we started in the fall to plan today's program, I was very struck by the action item of making the economic case for cancer control and prevention efforts. And certainly we all think, hopefully, that our work is valuable. But placing an economic value on our work is a different lens through which we can and often need to view our efforts. And this is the conversation we're looking to begin today and hopefully continue throughout the month on Research to Reality. And truly, I can't think of two better speakers who are more qualified in every possible way to start that conversation and to guide our efforts forward on R2R. So I'm very happy to introduce Dr. Florence Tango, who's a health economist. She works in CDC's Division of Cancer Prevention and Control's Epidemiology and Applied Research Branch. Florence is the principal investigator for a number of CDC cancer economic studies, and her work focuses primarily on the economics of cancer, as well as the economics of cancer screening programs and the use of breast and cervical screening cancer services. Florence will provide an overview of the economic burden of cancer and how one can best articulate the case for investment in cancer prevention and control. And someone who's leveraged Florence's analysis, insights, and research to the great benefit of the people of Kentucky is Jennifer Knight. Dr. Jennifer Redmond Knight is Assistant Professor at the University of Kentucky College of Public Health, where she serves as a co-investigator for the Kentucky Cancer Consortium. Jennifer is also a strategic planner for Kentucky's coordinated chronic disease prevention and health promotion efforts. And Jennifer will provide an overview of the Kentucky Comprehensive Cancer Control Detailed Resource Plan, a copy of which you can view on Research to Reality. The plan outlines current monetary and non-monetary resources available to the consortium and identifies strategies for getting and maintaining the resources needed to implement priority areas for the Kentucky Cancer Action Plan. Both biographies for our speakers can be found on Research to Reality at researchtoreality.cancer.gov. So following their presentations, we're going to host a robust, interactive discussion with you about your experiences and hope that you'll take some time to chime in, ask questions of our speakers, and share experiences of your work in trying to put an economic value on your efforts. If at any time during the presentation you'd like to be placed in the queue to ask questions, you can press star 1 and the operator will put you in queue. Or if you prefer, you can also submit your questions using the Q&A feature at the top of your screen. You just type in your question and then hit ask. We welcome those of you who are joining us for the first time and hope that you'll take the opportunity to engage in the discussion today on the call and online at R2R. We're just very grateful to have all of you with us today. So Florence, with all of that housekeeping done, I'm delighted to turn this over to you and Jennifer, so thank you.
Thank you for that introduction, Maggie. I also like to thank you very much for giving me the opportunity to briefly talk about the economics of cancer and cancer control program. Good afternoon, everyone, and thank you all for being here. This is the outline of my talk. I will start by listing the different types of economic analysis. I will present the economic burden of cancer at the national, state, and personal levels. This will be followed by a brief discussion of the economic analysis of two cancer control programs at the CDC, namely the National Program of Cancer Registry and the Colorectal Cancer Control Program. I will give an example of how one can show value for cancer control efforts. I will end my remarks by highlighting the importance of some of the most commonly used economic analysis methods. There are a number of economic analyses that can be used to answer a variety of economics questions. This includes cost analysis, economic evaluation, which includes cost effectiveness analysis, cost utility analysis, and cost benefit analysis. We also have cost minimization and also fiscal or budget impact analysis. There are a number of reasons why cost analysis are conducted. Some of the reasons are: 1, to estimate the economic burden associated with a specific disease or condition. This is generally referred to as cost of illness analysis. A second reason is to estimate the economic or financial cost of running a program. This is generally referred to as program cost analysis. Let's look at the economic burden of cancer. Dr. Angela Mariotto and the colleagues published a paper in the Journal of the National Cancer Institute that provided 2010 and projected 2020 estimates of the cost of cancer care in the United States. Assuming constant incidence, survival, and cost, they projected approximately 14 and 18 million cancer survivors in 2010 and 2020 respectively, with associated costs of cancer care of approximately $125 and $158 billion. We published a paper in Cancer in 2013 looking at the annual state-level treatment cost of cancer. Annual state-level cancer care costs range from $227 million to about $14 billion. Medicare paid approximately between 25% and 36% of this cost. Private insurance paid between 36% and 50%. And Medicaid paid between 2% and 9%. Cancer treatment accounted for about 4 to 9% of all state-level medical expenditures per year. This slide from the work led by my colleague here at the CDC, Dr. Ekweme, shows the annual per capita medical expenditures among cancer survivors and those without a history of cancer stratified by gender. As you can see on this slide, both male and female cancer survivors had significantly higher medical expenditures than individuals without a history of cancer. The excess burden for men is approximately $4,000, and that for women approximately $3,000 per year. Dr. Ekweme and the colleagues also calculated annual per capita lost productivity among cancer survivors stratified by gender. This slide shows substantial lost productivity among both male and female cancer survivors. Now let's briefly discuss the economic analysis of some of CDC's cancer control programs. Starting with the National Program of Cancer Registry. I will first give a very brief background. The National Program of Cancer Registries was established by Congress in 1992 and has since been administered by CDC since 1994. The National Program of Cancer Registries collects data on cancer occurrence and the type of initial treatment. Today, through the National Program of Cancer Registries, CDC supports central cancer registries in 45 states, the District of Columbia, Puerto Rico, and the United States Pacific Islands jurisdiction. This slide leaves the key economic questions that we have answered. The questions include: what are the funding sources for cancer registries? How much does it cost to register a cancer case? What is the cost per case for specific cancer registry activities? What factors impact the efficiency of operating cancer registries? How did we approach this study? We started by conducting site visits. We then, with the help of RTI International, developed and pilot tested a standardized cost assessment tool. That tool was used to collect data for 3 years from the registries that are funded by the National Program of Cancer Registries. This slide shows the share of registry funding by source. On average, more than 60% of total registry funding comes from CDC's National Program of Cancer Registries. This slide presents the estimated cost of registering a cancer case. The cost per case averaged across 3 years was $61 for all activities. When we look at just the core registry activities, the cost per case is $57, and if we focus on the advanced activities, it is $4. This slide shows the cost per case for the top 10 most expensive cancer registry activities. We also looked at the factors that impact the cost of operating cancer registries. The 3 key factors that significantly impact the efficiency of cancer registry operations are the case volume, data quality, and the region where the central registry resides. We found that the volume of cases reported had the largest effect. This figure presents the distribution of cost per case by case volume. As you can see, the higher the case volume, the lower the cost per case. This is a classic example of economies of scale. I will now briefly talk about the economic analysis of CDC's colorectal cancer control program. I will first give you a very brief background. The colorectal cancer control program started with a demonstration program in 2005. 5 sites were funded for 5 years. The objective was to explore the feasibility of implementing a national colorectal cancer control program in the United States. Lessons learned from the demonstration program informed the planning and funding of the first round of CDC's colorectal cancer control program, where 29 sites were funded for 6 years from 2009 through 2015. The aim was to increase colorectal cancer screening rates through providing and promoting colorectal cancer screening. The second colorectal cancer control program was just funded this past summer. 31 sites are funded for 5 years, from 2015 to 2020, to partner with health systems and increase clinic-level colorectal cancer screening in a defined population. Here are the economic questions that we are answering. What are the costs of the program? What are the costs to the individual? What are some of the cost-effective ways of promoting colorectal cancer screening? What are the benefits to the public? We are using several economic analysis methods to answer these questions, namely cost analysis, and cost-effectiveness analysis. One of the lessons that was learned from the evaluation of the first colorectal cancer control program and applied to the second colorectal cancer control program came from our cost study. As shown on this slide, we found that grantees were spending a significant amount of money on mass media, a strategy for which Community Preventive Services Task Force, or the Community Guide, found insufficient evidence to determine effectiveness. The recently funded 31 grantees are strongly being encouraged to use the evidence-based client and provider-oriented interventions. Because there are several evidence-based interventions, CDC is leading economic evaluation studies to assess the cost-effectiveness of colorectal cancer control program screening promotion activities. The results from this study will guide future selection and implementation of screening promotion interventions. I want to demonstrate how one can show value for a cancer control effort by sharing with you the work that we did. This was led by Simon Luke. In this paper, recently published in Medical Care, we used simulation models from CISNET to estimate the long-term implications of increased colorectal cancer screening in the pre-Medicaid population, those between the ages of 50 to 64. We wanted to look at the cost in the pre-Medicaid and in Medicaid population. We projected cost savings to Medicaid from screening people for colorectal cancer before they turn 65. Before I end my remarks, I would like to highlight the importance of some of the most commonly used economic analysis methods. Cost analysis provides information on the expenses related to delivery of a medical service or public health intervention. Results from cost analysis can be used to set budgets, to show accountability, to assess equity in resource allocation, and when combined with effectiveness measures, it can be used to conduct economic evaluation studies. Fiscal impact analysis helps policymakers determine whether a proposed initiative is affordable from a budgetary standpoint. A fiscal impact analysis can provide information on how an intervention will affect one's budget, but it won't say whether the intervention is an efficient use of resources. There may be other less expensive options that produce similar results. To evaluate which option creates the results you want at the lowest cost, you will need to use cost effectiveness analysis. Acknowledgement. Lots of people have worked with me over the years in conducting the economic analysis of the National Program of Cancer Registries and the Colorectal Cancer Control Program. For the economic analysis of the National Program of Cancer Registry, I would like to acknowledge the contributions of my CDC colleagues, namely Francis Babcock and Dr. Hannah Ware, as well as the contributions of Dr. Suja Subramanian and Dr. Maggie Cole-Bibi from RTI International. Besides myself, Dr. Emma DeGraff, Dr. Janaba, and Janet from CDC, as well as Dr. Suja Subramanian, Sonia, and Dr. Maggie Cole-Bibi from RTI International have been working on the economic analysis of the colorectal cancer control program. I would like to thank you very much for your interest and attention. Now I will turn it over to Dr. Knight, who will provide an overview of the Kentucky Comprehensive Cancer Control Detailed Resource Plan. Dr. Knight, over to you.
Wonderful. Thank you so much for it. And I have to say, for those of you who are listening, you should totally connect with Florence and the work that she's done. And we have used her work extensively in Kentucky. We're always excited when she has a new publication because it really is very informative and practical and useful. And she can understand things that go way over my head. So lean in to Florence when you can. So we're going to talk a little bit about our Kentucky Cancer Consortium's resource plan. To just give you an overview for those who may not be familiar, the Kentucky Cancer Consortium is Kentucky's comprehensive cancer control coalition funded by the CDC. And we're a little unique. The University of Kentucky is actually bona fide by our Kentucky Department for Public Health to be the agent for comprehensive cancer control in Kentucky. We have more than 70 organizations working together to represent healthcare, advocacy, government, and nonprofit. And I'll get into it later, but that link to the university is critical when it comes to resource planning and economic evaluation. So to give you a little bit of a rationale for a resource plan that we've thought about over the past several years is, one, it can be an identification of resource gaps and areas of need. So what do we need to fund and where are they? We can prepare for planned and unexpected opportunities to request and acquire resources. And I will say a lot of folks will doubt me on this, but those things have happened even in Kentucky. The benefits of a resource plan really helps us determine what's needed to implement priority areas in the cancer plan. Usually you can't do it all, so those priority areas are critical. You can plan for long-term sustainability for the consortium's priorities, set realistic expectations about what can and cannot be done with resources, and this can be particularly helpful in all kinds of fiscal situations. And then it also helps to garner resources that provide support to consortium members implementing areas of the cancer plan. So the challenges to resource planning include there's often conflicting opinions about the scope, the target audiences, and how to present the information. Some folks want us to figure out the cost for everything we could ever do, and other folks say that's not important, it's overwhelming. So coming to those decisions can be challenging. Identifying people with specific expertise is also challenging. Many times people around the table may not be familiar at all with economic evaluations or how do we find some of this cost information. And again, finding the data needed. And I'll go into that a little further as we go, but that can be really challenging. And then also the idea of converting strategies and even objectives in our cancer plan into tangible costs, not always an easy task. So to give you a little background on Kentucky's resource plan story, back in 2007 to 2009, several of us participated in some national discussions and workshops. And initially they were called budgeting or resource planning, and so we kind of stuck with resource plan, if you will, for Kentucky. At that time, we formed a small committee, and we developed Kentucky's first Cancer Action Plan resource plan in 2009 and 2010. What we did as we thought about where do we focus our energy is we just picked two areas of our cancer plan and said, what would it cost to really fully implement what was needed for these? And so as you can see, some pretty large numbers. Tobacco prevention, we need another $52 million, and colon cancer screening, $17 million. So what we learned in that are critical lessons. One, and please no offense to my colleagues at CDC, but we had way too much public health CDC language that could be used to educate those who we were getting money from or hoping to get money from. So potential funders or policymakers looked at our plan and were like, that's got too many pages and too many words. So we really thought, okay, this is not going to work as well as we'd hoped. The other piece is the total needed, over $69 million for just two areas, was really overwhelming to partners and decision makers. When we presented this as here's our need, they just wouldn't even look at us again because it was such a large ask. And in a state like Kentucky, so many of you guys are probably familiar with your state, this number is just not even considered from a health perspective, unfortunately. And the other piece is we learned that many consortium members weren't sure that it was a good use of time because fiscal challenges were happening. I mean, we finished this in 2010. Everyone knows what was happening in 2008, 2009, and even in 2010. Why would you come up with such an ask? However, I'm going to encourage you guys to be positive and to keep on at it because what we had happen is we had a chance to meet with a 3-time cancer survivor and a professional fundraiser who decided he wanted to make a difference in cancer. And I remember when we first met with him, and actually he sought us out. He found our cancer plan, and he found our resource plan on the website. So, wow, it really was looked at least by someone. But he said, what can be done? I want to make a difference. How can I make a difference? And in February of 2012, Governor Beshear, our governor at the time, formally announced the Kentucky Cancer Foundation with the purpose to fund priorities of the Kentucky Cancer Action Plan and the resource plan. Well, one of the first things that he said in coming into this role is, okay, so your first resource plan got me thinking, but we can't use this to actually raise money very well, so let's look at it again. And again, we need to be a little less public healthy in our language and more business and funder friendly. So we then developed our purpose for our resource plan. And I say then developed. Here is the purpose, and I'll tell you a little bit of the background. We wanted to educate healthcare decision makers, elected officials, funders, and interested Kentuckians on the potential to decrease the cancer burden in Kentucky through supporting cancer prevention and early detection as defined in the Kentucky Cancer Consortium Resource Plan. And the reason I said purpose now is that really initially we kind of knew this was the direction, but it wasn't until we went through our dissemination and communication planning that we realized we had not articulated this very well. So I encourage you guys to learn from our lessons and our maybe mistakes made. Do this early and really get that clarity early. That will help you along the way. So then I want to highlight some partnerships, and these were critical. Obviously, our new nonprofit, the Kentucky Cancer Foundation, was a key partner in this. And then we also really engaged local healthcare systems leaders, business leaders, as well as our traditional public health and nonprofit partners. It was really essential to bring in some of these other folks who weren't in on the beginning of our resource plan, but these healthcare systems and business folks who just saw things differently and helped us figure out how we need to communicate to our audiences who might be willing to give money. The other key partnership, and as I mentioned at the beginning, was our University of Kentucky College of Public Health Health Economists. They were invaluable at reviewing our work and thinking through things and helping really educate me on economic evaluations and what could and could not be done. We also relied heavily on our University of Kentucky Markey Cancer Center Communications Office, who helped us with formatting and design and layout and making it really flow and work together nicely, because when it was just me, it was a really sad Word document. So the process that we took is we met with our resource plan team and we said, where are we going to focus? And what we decided to do is let's focus on prevention and early detection for lung, colon, breast, and cervical cancers. So we reviewed the literature for these cancers. We looked at cancer prevention and early detection data. So what is the screening data? What is the smoking data? What do we know about Kentucky? We looked at our census data to get a sense for population information, who's at risk, and what are some of our populations at greatest need. We looked at our cancer surveillance data, so what is our burden of these cancers, our cancer treatment costs, which was a little bit challenging because one of the things that I found was there were very few published literature resources that had consistent treatment costs. You might have something on colon cancer, and then you might have something else on lung, and you might have something else on breast, but when you're trying to combine them in a similar way and have similar costs, it was very difficult. So we ended up using Medicare data, which everyone says, that's too low, it really costs more, but we didn't have any data for it. So I'll get into that a little more later, but that was a tricky piece. We also then looked at cancer prevention and early detection costs. So what does it cost in Kentucky for tobacco treatment and nicotine replacement, or what does it cost in Kentucky for colon cancer screening? We tried to find information on return on investment for cancer prevention where we could, and then also the impact on businesses and employers. And Florence already highlighted some slides on the economic impact and the lost productivity, which is tremendous when it comes to cancer. We also determined which of these data to use. Obviously, you couldn't use everything, but we wanted to use what made the most sense and focus on Kentucky. And as I mentioned before, we asked for lots of advice from our UK College of Public Health colleagues who had that health economics expertise. So then, as a team, we really said, as I said before, what data do we include? And then what's the best way to present or translate this data to be useful for decision makers, elected officials, and potential donors? Again, considering our audiences How do we communicate that? And it was not the way we communicated the first time. And so I encourage you to be really open about feedback on this makes no sense, or, you know, maybe this would make sense and still be accurate, of course. And then we decided on the order of information. I'll never forget, like, we literally sat in a room, we had the slides, and we had all the different sheets, and we worked together to say what goes what and how does it flow to make the most sense. And then we worked as a team to develop a dissemination or media plan, if you will, to say, how do we get this out? And I'd already mentioned before, we worked with our Cancer Center Communications Office that really helped us with our layout, design, and formatting pieces. So I want to highlight a few problems that we overcame or continue to overcome, but this is something you should expect. One is, at times, I know some of you may have never experienced this, right? Unrealistic partner expectations. You have those who have never done an economic evaluation, and they underestimate the time or complexity it takes to develop a resource plan. And they say there's no reason this should be difficult. You should just add a couple numbers, subtract a couple numbers, and here you go. It's not that simple, and I continue to learn that, but then use it as an opportunity to really educate these folks on the data needed and involve them in advocating for that data. What we've discovered along the way is folks do not want to fund data until they realize that you need data to fund your efforts. So this has really helped kind of bring to light the importance of good data. The other piece is we really needed to expect it to take longer than we planned. The reality is researching the data, finding these articles, finding local Kentucky work, or even in any local jurisdiction, where is that and who's got it and who's willing to share it? It takes significant time. And the other piece is working with business and funding partners provides that practical perspective, but it also takes some time to negotiate decisions about what to include and exclude. You've got a lot of different people who think very differently. So how do we come to a collective kind of solution for this that can move forward toward our target audience? So that just takes some time, some listening, and some revisions. The other piece to consider is you probably won't find all the data you want or need. And I alluded to this, particularly related to cancer treatment costs. I had so many colleagues come to me and say, well, I am a clinician, I am a physician, and I know that cancer treatment costs way more than what you've got in here. The problem was I couldn't verify it with any data source because we couldn't get the data that we needed to do that. So what I would encourage you is advocate all you can, build those partnerships, and try to promote the need for funding and support and sharing as collecting this data, maybe claims databases. I know that's one of the things the university is working on. But the other thing is you've got to be flexible and willing to make decisions with limited data. Don't let it just stop you in your tracks. Sometimes you just have to move forward with the limited data you have so that you can make the impact you'd like to make. The other important problem to consider, depending upon what you're doing, is some of the compelling data may also be controversial. So one of our sections, as we talked about the need for funding, particularly tobacco prevention efforts, lung cancer screening efforts, is the underpricing of cigarettes is what we called it. But we really talked about how much we get back from cigarettes in the form of tobacco taxes and other things, and yet how much we spend on health. And while that is very true and very compelling, we were releasing that at the same time we were part of partners promoting comprehensive smoke-free. And so our policy leads were like, what are you doing? You're confusing the message. It's an important message, but the timing is important. So definitely work with those partners again to find out when the right time is to share some of this and how is the best way to approach it. And then I will also say disseminating and promoting the resource plan takes significant time and effort. Just finishing the plan is not the last step. And for me, that's sometimes unfortunate. I will say once it was done, I wanted it to be done. I was so tired of working with a resource plan. But the reality is it doesn't do any good if it just sits in my shelf or with some of the partners that we've worked with on this. It really needs to be less broadly to, all kinds of populations, and then also targeted to those audiences you want it to reach. And one of the things that I would encourage you in this as well, and I know it's something in Kentucky we have a tendency to move to the next thing, but the reality is it's so critical before you move to the next thing is to really spend some time in that dissemination promotion and to make my CDC colleagues feel a little better, those communication media plans. they really are important in getting the word out. So our resource plan, a brief overview, and this is just a really, really small piece of it so you could see some of it, but our full resource plan and our executive summary are on the web. The way we ended up approaching it, rather than looking at, okay, it's going to cost us $69 million for X, Y, and Z, we decided to translate it into what can we do. So for every $100,000 invested in cancer prevention and screening, which might be a more palatable number for our funder, we can support smoking cessation medications, 666 of them. We can support lung cancer screening, colon cancer screening. And so this really helped us paint a picture to say, oh, this is something doable. In other parts of our resource plan, we also highlighted what happens if we don't. And we looked at the cost of late-stage cancers. So for every $100,000, you can treat 0 late-stage lung cancers, 1 late-stage colon, 1 late-stage breast, and 1 late-stage cervical. And then we also kind of upped the ante. So for every $500,000, and you can see kind of some examples here, we've made it really tangible how many people could be impacted if we just invested this money in cancer prevention and screening. And again, we had the converse slides that talk about we could treat 4 late-stage lung cancers or 8 late-stage breast cancers. And so that kind of goes in and you contrast, wow, what would happen if we really invested in these? We could really make some impact. And then again, we went to our $1 million mark. For those who wanted to invest $1 million, look what the impact could be. So again, this is the approach that we took. It may not be the best fit for everyone, but this is, again, the way we approached it that made a lot of sense to us. So possibilities for those who are considering this or looking at it again, and many of you may have already done resource plans and you're ready to revise one, or maybe you're not ready, but you're getting some pressure to do it. Hopefully this can help think about that. So what I would like to encourage you guys is build those partnerships with businesses, healthcare systems, health economists, and others who see the world through dollar signs. It's so critical to have folks like that at the table really providing some good feedback and input on what's going on, and listen to them. They've got some great insight. And then use the data you can find and advocate for more tailored data in your state, tribe, or territory. Again, once you get into this process and you realize the great need, you will become an advocate for finding this data, sharing this data, and identifying resources to make it possible. I encourage you to partner with communication experts for the presentation of your resource plan, and then develop a resource plan that works for your tribe, state, or territory. For this, we thought that this for every X amount of dollars approach would really work for Kentucky. It may not work for you. So really sit with your partners and your stakeholders and figure out what works for you. And then I'll end with be positive. As I said before, there may be potential for funding that you've never thought possible. And having a plan really creates those opportunities and conversations to move things forward in a way that we never thought was possible in Kentucky, although we hoped it would happen. So for more information, feel free to email me. And if you have questions, I know we'll have some question and answer time here. And there's also a link, and I think there'll be a link on R2R where you can download our full resource plan and executive summary. And as it can be helpful, please utilize it. And that's what it's there for, to really make a difference and help support all of us garnering and using resources the best we can and make an impact on cancer. So with that, I'll send it back to Margaret.
Great. Thank you so much, Jennifer, and thank you, Florence. I have to say, several months ago when this project, when today's presentation was just a little question in everybody's mind, how could we do this? I really, I never thought that everything would crystallize as well as it did today. So I thank Florence and Jennifer so much for your time and attention in putting together such thoughtful and valuable presentations. Really did such a beautiful job, and thank you. And I just want to tell everyone that the references that Florence noted in her presentation, as well as the resources that Jennifer spoke to, can all be found on researchtoreality.cancer.gov, and we will have an archive of this presentation that will be available next week, hopefully, as well. So you can share all of that with your colleagues as well. So this seems like a great time to open up the phone lines and and the live meeting session, and give you an opportunity to join the discussion. So if you'd like to ask your question live, you can press *1 to be placed in the queue. And or if you would prefer, you can submit your question using the Q&A feature at the top of the screen. You just start typing in your question and then hit ask. So while I'm waiting for people to queue up, either by pressing *1 or typing in the Q&A box, Jennifer, I'd just like to ask. I was very struck by something you had said in a session when we were planning this about working with economists, and Florence, you also spoke about this too, about how difficult the two worlds, or just what different worlds we all kind of work in. So I was curious for both of you, what do you find is to be the best place to start in brokering those relationships, to kind of reaching out and finding those people that can be most helpful in putting together an economic plan?
So I would say really my best source initially was the University of Kentucky, and particularly our College of Public Health. And so what I would suggest is identify and look up some of your schools of public health or colleges of public health in your state, tribe, or territory, and see if you can identify some folks with those health economist backgrounds, and perhaps ask some of your partners as well if they have worked with anyone. That really became an important place to start, and that helped tremendously.
Mm-hmm. And Maggie, from a national perspective, doing economic evaluation from CDC and working with programs, I physically sit in the epidemiology and applied research branch, and we have a branch that runs the programs. So it is very, very important not only to have economists, but to have people who understand the programs, and also to have people who are actually running the program, because they are the ones who actually know what resources are being used and how to get the information. So different partners do bring different skills to the table.
Well, and I will kind of add to the university, oftentimes many university partners are looking for projects and things to do, and while this wasn't on their radar, it brought up some opportunities that would create new funding or research questions, and that can be really mutually beneficial. So we're providing the field and really those resources to help the researchers figure out what to do.
Oh, I think that's a great point on both fronts. You know, it's hard to sometimes identify who those people are, and then, but once we all hook up, and certainly Florence, your point too about having the program people, program staff really kind of leverage their expertise in terms of what elements go into the program and how is it even possible to begin to cost those out as well. Mm-hmm. Jennifer, when you're looking ahead for next steps in terms of the resource plan, what will be some aspects that you'll look to do differently? I'm thinking particularly around the Affordable Care Act and how those kinds of things. Does the changing landscape of health care have an impact on the work that you're doing?
Yes, as a matter of fact, it does, and we've had some conversations around that the idea when we started is that we really needed to focus on services that would be needed for those who did not have insurance or access, which can be two very different things. But what we discovered in this process is a lot of folks are having more access now and have in Kentucky. We've been very fortunate, and I think we've made the biggest leap, if you will, in terms of the least number of uninsured now. So we've got folks who may have access to some of the resources, but one of the things we're going to think about is you may have insurance, but that does not mean you have access. And there's other barriers and other issues, whether those be navigation or transportation and education. And so there's a lot of pieces and parts that I think have cost to them that we need to look at again and figure out how do we cost out the continued need for Kentuckians to be able to reach the resources that are needed to make those impacts for prevention and early detection.
Right. And a related question that came in, and I should say not from one of my Kentucky in-laws, says, how does the consortium feel the new governor will affect the plan in Kentucky? And Florence, maybe a broader perspective. I mean, how can coalitions and groups work to make their plans and their cost evaluations kind of sustainable, you know, in changing political environments?
That is a fantastic question, and still to be determined in some ways. But I think that, you know, even our new governor is looking to find fiscal savings and find areas where we can cut some of our costs and we can have a better state overall. So I think one of those things is going to be having some conversations with he and his staff about what they see as needs, what they see as funding issues, and even presenting some of this to them. Did you know some of the costs related to cancer? Because I think a lot of folks don't realize the burden, and Florence gave some great examples, and we have some in our resource plan. But I think in many ways it's going to be building some of those relationships, and perhaps in considering our target audience, we may need to tailor some things that would resonate better with a new administration than an older administration in terms of resources needed. So again, having those conversations, being open to change, being flexible, and really working to identify those costs, and again, find those partners who can find some of that data that's not always easy to find.
Mm-hmm. And just to add, from the national perspective here, the colorectal cancer control program has been around for a little bit, as I indicated on the slide, but the second round was just funded last summer. And what we had done in the past in terms of economic evaluation, we had just focused on the cost of promoting, the cost of providing screening. But now the focus of this program is actually to increase the screening rates. And one of the things that we are really looking at is that there are lots of evidence-based interventions, as you can see on this slide, both from the client side and from the provider. And these interventions have different costs. So one of the things that we are really focusing on now is to really look at which of these is cost-effective. And that will really, really help the grantees to be able to allocate resources where they can get the highest screening rates.
No, and I think that's an excellent point that both of you make in terms of both the, you know, there are very many ways to communicate the information, and also, you know, we are looking to do things always, you know, with more and more effectively, both from a cost as well as from a program perspective. We have a question from Jenny who asks, hi, Dr. Knight. Was there a plan for treatment costs if a cancer is identified after screening in those who are uninsured, or how do you begin to factor that in?
That's a great question. For this particular resource plan, we really focused it on the prevention and early detection piece, so that was the focus of this plan. But one of the things that I think we have done as an overall consortium, not necessarily in this plan, is to continue to connect people to resources. And one of our sister programs, we like to say the Kentucky Cancer Program, has regional folks throughout the state, and they have something called a Pathfinder, which is even electronic, that can help connect people to resources in their communities. And so this includes, okay, what happens if I'm uninsured and I've been faced with cancer treatment? Where do I go? And so we have a lot of folks in health systems, healthcare systems in Kentucky that are willing to take folks on. Now, they won't admit it necessarily, so they may not put that in writing, but as you build those relationships and you get to know that, folks are really committed to trying to navigate people to the resources they need for the treatment that they need.
Great, thank you. And I think that that's such an important point also. What about the people who are outside systems of care? What about, those costs that would be higher than anticipated if they're captured differently? Florence, I have just a question asking what's coming down the line. Jennifer was saying before that she always keeps an eye out for your publications, so we'll put you on the spot and ask what are some things that you're working on now that our partners can look to leverage in the future?
Okay, great question. Thank you, Maggie. We are just completing economic evaluation of the first round of the colorectal cancer control program. So we actually have 3 papers that we are hoping to publish as a series in preventing chronic diseases. And that paper will look at the cost of the program. From both, there will be one that will look at the cost of providing screening for colorectal cancer, cost of promoting screening for colorectal cancer, and one other important paper and piece of work that we did is sometimes you have these colorectal cancer control programs or screening programs that we think are free, but sometimes we find out that the take-up rate is low. And one of the things that we decided to do in the second round was to really look at it from the patient or the client perspective. And we had a survey developed. We obtained OMB clearance, and we worked with a few states to really ask and interview the people that were coming to obtain colorectal cancer that was funded, screening that was funded by CDC, and to find out what cost did they personally incur, because if the cost of them coming to obtain colorectal cancer screening is higher than the wages that they will forgo, or the cost of transportation, or the cost of paying for care for an elderly person or a child, that may deter them from coming to obtain screening, though it is paid for. So there will be 3 papers that will be coming out hopefully sometimes in the summer. And then in terms of the evaluation of the new colorectal cancer control program, we just started that project in the summer. So we will be working with a few grantees that are interested in looking at cost-effectiveness analysis.
No, it's true. I think when you look at the broader economic impacts of all of those issues, transportation, childcare, for free screening programs, it really does put another value on what is free, and even time off from work factoring in also. So we'll look forward to that, Florence, and look forward to working with you to disseminate those out to help people kind of pick up that information, their coalitions, to use that further. And Jennifer, you popped on the call with some good news about some upcoming work for you. Is there anything that you'd like to share in terms of next steps with some of the work that you have moving forward?
Sure, absolutely. One of the things that this resource plan has helped to provide in Kentucky are a few different things, and I'll just give a brief overview. Over the past really 4 years now, which is hard to believe, we have had, with this Kentucky Cancer Foundation, a public-private match with our colon cancer screening program, and that has been tremendous, and really this resource plan helped to make that happen. We also were selected as a Bristol-Myers Squibb Foundation grantee to address lung cancer survivorship, but it also incorporated provider education as well as prevention and early detection. So a very large grant that has come to the University of Kentucky, University of Louisville, and Lung Cancer Alliance. And then most recently, literally as of last week, we found out as a consortium that we've just received a small grant to do more lung cancer prevention and control, really focused in southern Kentucky, in work sites focused on males. And so we're really excited to partner with the Self-Made Health Network is who they are. And stay tuned. We're going to work on some press releases and things related to that. But we're really excited. And I think that so much of what happens is sometimes it feels like it's impossible, or how are we going to find these opportunities? But when we really communicate the need, those opportunities might pop up in unexpected places. So we're excited to continue the work to do something about cancer with new resources.
Great. Well, I can't think of a better way to end than looking ahead. And you know, along those lines, we're really so very happy to have Florence and Jennifer as such integral members of the Research to Reality community, and hope that you'll take some time to visit us on Research to Reality to join the discussions. And we have a very, you know, we really specifically invite you to ask your questions about economic valuation and to begin to share your stories. We really hope that we can gather a group of us who are working on different aspects of putting some value on the work that we do and helping create a very evidence-based, economic-based voice for the effective programs that are going on at the state and local level. So we're really excited for that and hope that you'll be joining us here. Also want to, yesterday we began our featured partner with the Pink Ribbon Red Ribbon campaign, which is another very successful program that's working in developing countries around cervical and breast cancer. And throughout the month, they'll be populating R2R with some of their stories from their local sites. We'll be replatforming and redesigning Research to Reality in the next 2 weeks. So this session is early, and then we're going to take a little programming break at the end of the month and hope that you'll be able to join us in March for just a quick 20-minute cyber coffee to talk about colorectal cancer screening initiatives, just a little update from 80 by 18 and those initiatives and all the wonderful work you have going on there. So we'll have details and registration on in late February. But I'm sure I'll see you before then on Research to Reality. So thank you very much for joining us today, and thank you again, Florence and Jennifer.
Thank you. Thank you for having us.